now. Thank you all for being here. This is a Workgroup 3 that's part of the Joint Subcommittee to study mental health services in the Commonwealth in the 21st century. I want to welcome everyone for being here. We have just 3 members that are official members of this work group. And why don't we go ahead, Mr. Jackson, do you want to call the roll?
Yes, sir. Delegate Rush.
I believe he is here.
You. Yeah. Senator Mason.
Here.
Delegate Hope.
I'm here.
And we have Senator Deeds.
All right. Mr. Uber Chair, welcome. Glad that you could be here and glad that Delegate Cox can be here. So why don't we just go ahead and go through the first item on the agenda. We're going to take up, for the public's edification, we're going to take up a couple of bills that were carried over during the 2021 session. And we wanted to take another second look at those bills. And then we're also going to discuss the organization of the mandatory outpatient treatment, if there needs to be a rewrite to better organize that part of the code. So that's going to be the agenda, at least for today. So unless there's any questions from any of the members, why don't we go ahead and proceed. The first bill, and call up the House Bill 2329. It was carried by Delegate Cox, who presented his bill. I believe it's to HWI Subcommittee. And it was decided that we would carry it over and study here in the work group. So Delegate Cox, do you want to present the bill? And I know you do have someone here to testify. We do have people from the public as well that they'll have the opportunity to testify if they desire. So Delegate Cox, welcome.
Thank you. Thank you, Delegate Hope. Let me do this. I'll give a brief description. Then I'd like for Kanika Pride, who brought this very serious issue to me this past summer, to maybe talk about the exact circumstances, and then I can obviously answer any questions. I think she can sort of talk a little bit about, what exactly happened, et cetera. But the bill, and also just for edification, I sent hopefully a fairly detailed letter on February 15th, 2021. And I think Delegate Hope, you and Delegate Sickles obviously was addressed to Delegate Deeds, but sort of lays out both what the bill does and what the case did, et cetera. So you have that, which gives you a little bit more detail in the bill. But the bill aims to prevent a premature release of a patient who's been involuntarily committed under a TDO. It deals with both a community hospital and a state hospital. It states that if you're going to be discharged within 96 hours of an involuntary commitment, that you have to have an additional psychiatrist evaluate the patient, determine that patient no longer meets commitment criteria. I think a lot of you know that it's a pretty involved process to go through the TDO process. And obviously, once that judgment is made, it's usually 15 or 7 to 30 days. I think in this case, it was 7 days. And so I'm going to, if we can, have Mrs. Pride come in, she'll sort of discuss what happened and why this was such a serious case and the reason for the bill.
Thank you, Delegate Cox. Ms. Pride, welcome.
Hi, hello.
Thanks for being here.
Thank you. Thank you for the opportunity. I've kind of written my statements today because I don't want to miss out on anything. So bear with me. Commission members, senators, and delegates, thank you kindly for the opportunity to testify in support of House Bill 2329. I also express gratitude to Delegate Cox for hearing my concerns and taking action. Thank you. I wondered how I would approach this matter today, and I've decided to do a timeline. My father was murdered on January the 11th of 2016 in his home. In the weeks leading up to the murder, his killer, my cousin, was clearly in crisis. In early December, he was committed to Poplar Springs Hospital, where he demonstrated a capacity towards violence there, having assaulted another patient during his stay. He was released, and a short time after, he was arrested for assaulting 2 members of his church at a holiday party. He was jailed and able to bond himself out with an agreement to answer to those charges in court at a later date. He was unable to answer to those charges as he had checked himself into Southside Regional. It was a voluntary commitment. During his stay, which was about 7 days in entirety, on the 5th day of their treatment, he smothered another patient with a pillow. This changed the circumstances of his commitment from voluntary to involuntary. A 7-day TDO was issued, and yet he was released the following day, a Thursday evening. Excuse me, just 1 second. So he was released on a Thursday. On that Friday, he was able to use a recently issued debit card to rent a car. He called a family member, clearly still in distress. His focus at that time centered around getting a job. She gave him advice. The next day after that, which was a Saturday, he shows up at his sister's house unannounced and behaving erratically. She chose to barricade herself inside of her home out of fear. The next day, Sunday, he showed up at his home church, again behaving erratically. He made threatening statements toward the pastor and other members of his church. The police were called twice. They elected not to take action. The reason that was provided to me was that they could not confirm his identity, and they knew that he had mental health concerns. Well, the next day, Monday, somewhere around this time, he went to my father's house and brutally murdered him, stabbing him multiple times. The back of his head was crushed. His killer was clearly full of rage. This was only the 4th day after he was released from his TDO early. He still should have been in their care when the murder occurred. The decision to have a TDO granted is a group decision that is the result of an input from a treatment team. I don't understand why a provider can then make a unilateral decision, as in this case, to let a patient go early. He smothered some with a pillow 5 days into receiving treatment from them. What could he have possibly demonstrated in that 24 hours that would prompt her to discharge him early? What we are asking for is minimal. It is essentially a peer review. 2 people need to be in agreement that an early release is the correct option. A peer review might have saved my father's life. In this process, I have talked to many mental health providers, and none have been able to understand why she authorized the release of someone who was in danger to himself and others. And that is basically my testimony. I'm available to answer questions. As a part of this testimony, I have also a graphic available. Before looking at this graphic, I want you guys to know that it's graphic, but I also want you guys to see the consequences of the choices that she made. Also in Virginia, there is a statute that protects her in her decision making. As long as the patient does not specify whom they intend to kill, she is not liable for what he does. We have no recourse on the civil level. We have no recourse on the criminal level. Our case was dismissed in circuit court in Petersburg because of that statute. It was referred to the Supreme Court, who decided not to hear it. We do not believe that was the right choice, but we are not in control of that. And like I said, I would like you guys to see with someone whom she said was fit to be released back into society did only 4 days after he was released, in addition to all the other things. So here it's coming.
Right. Thank you, Ms. Pride.
This is my dad, and this is what happened to him in his home.
Thank you, Ms. Pride.
You know,
Thank you for sharing that.
Do something.
Thank you for sharing your testimony.
Okay.
Sarah, just for my understanding, if you understand this, and I will throw this out to the other members if they have any questions. What is the process now for someone to be released from the hospital under current law?
All right, one moment. I'm having some technical issues over here. So my understanding is that in this case, we were talking about Ms. Pride's type situation. What you have is somebody that was subject to a TDO, and that person can be released prior to the running of the TDO. So usually we talk about people are being released at the end of that TDO period. This is someone who can be released prior to the running of the TDO. And it does, doing this very sort of quickly from memory, the person who operates the facility at which the person is located can make that decision to release a person prior to the end of the TDO.
Okay.
And there's a statute, well, I already explained
Delegate
that.
Hope, I think in practice, though, what ends up happening is, administrators are very busy. I think what happens in practice is that one psychiatrist usually, if signs off on the release, that's what happens.
Okay.
And I think what we were trying to accomplish is that these are tough situations, obviously, and you might occasionally have someone that I don't think very often that, they might have been suicidal and the safety plan wasn't into effect yet. So, maybe the shorter window, there's a reason for that. So the second psychiatrist might sign off on that. But in this particular case, I think the process. I mean, you've already had the crisis clinician come in, the magistrate, then you've had the 72 hours where you've had the hearing, the special justice. This was a pretty egregious case. And look, I'm not going to get into judging people, but I do think if you talk to a lot of clinicians, occasionally you do have, some situations where, patients like this, they don't want to deal with. And you end up with, everyone's got a reputation, but you do have some cases. I don't think this is just isolated. I think you have some cases where this happens too often. And this was the solution that we were trying to think through. So what's the best solution? I think the thought was that second psychiatrist, if it was a safety planning case, would sign off. They're certainly not going to put their license at risk if they go, boy, this is really out of the ordinary. I'm not going to sign off on this. So that was our theory behind sort of coming up with this solution.
Okay. Thank you, Doug. Sarah?
And to clarify, sorry, it took me a moment to get the statute pulled up. But to clarify, exactly like Delegate Cox was saying, what you have is when we're talking about a person who's still subject to the TDO, the person may be released when, in the judgment of the director of the state hospital, the person is either recovered, does not have mental illness, or they're not recovered, but their discharge would not be detrimental to the public welfare or injurious to the individual. So that's what the code specifies.
Okay. David, did you have something you wanted to add to this? David's a special justice, and I don't know if you wanted to say something. Your hand is up. You're on mute.
Unmute. Okay. All I was going to do is just point out that the code requires that the person prior to being released be examined by a psychiatrist, which, in many of the cases, the evidence that comes before a special justice prior to commitment may just be from a therapist or somebody with much less training. And that psychiatrist must advise the director of the hospital, and it is the director of the hospital who approves. So I think that you already have in place a two-part check system, though the director may be very inclined to follow the recommendation of the psychiatrist. But that's all I would.
Okay. No, thank you. That's helpful to know the current process. So I'm instructed by Mr. Jackson that if any member of the public would like to speak on this bill, to raise your hand, and Mr. Jackson will bring you into the waiting room or bring you into the room to speak. So if you have something to add to this bill, please raise your hand and we'll bring you in.
Chair Hope, we do have one person, Jennifer Spangler,
Okay.
who would like to speak.
All right. Ms. Spangler, welcome.
Thank you. It's good to be here. I am so sorry for your loss. That was a terrible thing to happen. Absolutely. One of the things I'd like to bring up here, though, is could it be possible that one of the issues here is a lack of community services to help this individual rather than having them be locked away for good in a facility? But if they could have had some services in between, that could really help. And I'll just add, I have been TDO'd before multiple times. I have never had any violence, so that is a distinct difference.
That is very much a distinguishing factor.
Yes, and I completely agree with you.
That is very much a distinguish. Oh, I'm sorry. Go ahead. I'm sorry. Were you ready? I'm sorry.
And so I just wanted to just bring that thought to the committee.
Thank you, Ms. Spangler. Thank you.
Oh,
Mr. Jackson, is there?
Can I? Oops.
Yes, ma'am.
Oh, Hi, guys. I'm still here, but I don't know how to get back to you. There is something that I want to add to that. Let me see. I'm sorry. Oh, okay. I found it. I did have some feedback for the young lady. I don't know if I'm out of order or how this goes.
Well,
But I
yeah,
did-
briefly, if you want to. Yeah, we normally don't
Okay,
have
I
it back
do.
and forth. But
He was very much involved with his local CSB, but he was also not compliant with his treatment in terms of not willing to take his medication, not following up with his appointments. And, there's nothing that can be done to make him do that. And essentially, there's nothing that can be done until he does something. My concern is for people like him who have a demonstrated propensity to violence, along with a very significant mental health diagnosis, as he is diagnosed as paranoid schizophrenic. And like I said, with the violence that he demonstrated under his care, I don't understand how whomever can still authorize for him to be released under those circumstances.
no,
And yes, I do believe that CSBs can be valuable, but when you have someone that is not compliant to their treatment, that changes the circumstances, particularly when they demonstrate their capacity for violence.
Yeah, no, thank you, Ms. Pride. Are there, Mr. Jackson, is there anyone else that wants to speak to the bill?
No, sir.
Okay.
No more.
Are there any questions from the members?
Mr. Chairman,
Yes,
Monty.
Senator Mason.
First, thank you, ma'am, for your testimony. I'm very, very sorry for your loss. She said in her testimony that everybody that reviews this case says there's just no reason this person should have gotten out. And Mr. Weiss may have just told me that this is wrong, but it was my impression when a CSB is involved to put someone in a hospital that, yes, the hospital psychiatrist and team says they're eligible for discharge, but then the CSB team had some role as well. With this case, with the smothering or the attack on the patient, did they miss a step with the courts, or did they miss a step with a magistrate? Or, was there another mechanism that should have been there that was just missed? Or did they not have to go through that? And I'm just trying to get to this is a horrible and egregious circumstance, but was there a step in place that was just missed, or do we really need to change the code and fix the law?
That's what I'm trying to struggle with, is even if there were another layer involved, would that still have made a difference? In other words, would they still have not released this individual? And that's what we need to know. Ms. Pride, did you want to respond to Senator Mason's question? You're on mute, Ms. Pride. Ms. Pride, can you hear me? You're on mute. We can't hear you.
Okay. I'm sorry.
All right.
Sorry. Okay. Like I said, he was deeply involved with his CSB in the process, and they were aware of his hospitalization, the things that he did. And like I said, when we were involved in our civil case and we got the opportunity to, the people from the hospital had the opportunity to testify, his behavior was then described as horseplay. So they sought a TDO for horseplay. It's not credible, this process, which is why it requires some oversight, because there's too much leeway about how the provider can choose to justify their decision to release someone early. And therein lies the problem. If the issuance of a TDO is not a unilateral process, then the release of someone early from a TDO should also not be a unilateral process. What has changed and made a group of people to decide that they need to be TDO'd versus one person making the choice to say, oh, they're ready to go? Yeah. And again, the way that the laws stand, there's no accountability for their choices.
Yeah. Ms. Daly, I see your hand raised. Did you want to speak to this briefly?
Yeah, Ms. Pride, I also want to extend my sympathies to you. Your testimony is very touching. And I want to just basically weigh in and say, I on behalf of a national nonprofit that looks at civil commitment laws in many different states, that this is actually a very common problem. And it definitely is the case in many jurisdictions that you go through quite a lot of process in order for a person to be involuntarily committed. And in many jurisdictions, it is the case that entire, the discharge decision can come down to, who is on duty at the time that the decision is made. It really is like when the discharge decision is based on the opinion of one medical professional, it really does allow for people to fall through the cracks pretty easily. So I just want to confirm that this really is a very serious issue, and it comes up a lot more often than people might be aware of.
Thank you.
Mr. Chairman,
Yes.
Delegate Rush.
Yes, Delegate Rush, you're right.
Would it be appropriate if I asked Ms. Daly a question?
Of course.
Thank you, Lisa. You said you work with these laws throughout the country. Is there something similar where it takes a two-person step to release early from a TDO in other states?
I would have to look for a good example. There are a couple of states where there is additional process at discharge, but by far the most common practice is that the decision to discharge is left as a medical decision by the treating psychiatrist at the hospital. I would have to look for a good example of any kind of statutory fix to that.
Thank you.
Yeah, that's exactly what I was thinking, Delegate Rush, is what are other states doing in this circumstance? I'd like to know. Delegate Cox, did you have anything that you wanted to close with?
No, I really do appreciate the time. I will say it is, this is a really tragic situation. I did do a lot of research in this, and I think most of the psychiatrists on the state are really good. You will hear cases or several that they have a pattern of this, and it's these very problematic cases. We don't have a great system. I would say, Delegate Hope, in some ways there probably should be a clear pathway. If you're a hospital like Southside Region, we can go into the state system. There's no clear pathway there. So a lot of times I think these hospitals don't see they have a great option. But boy, in this case, and that's why we came up with the second sign off. That was the best thing we could come up with. But I guess the bottom line for me is we just need a system that stops this kind of, premature release. Whatever the solution is, this is the one we came up with. But there's got to be one, because can't have this, this kind of horrific situation happen again.
Yeah, I agree. I totally agree. All right. Ms. Pride, did you want to say anything, closing remarks? Because we're going to move on to another bill.
It's not necessarily a closing remark as it is. It's just that I guess I'm curious, and maybe this is something that somebody can get back to me and help me to understand, is that what would be the hesitation in adding this additional safety measure? What would be the hesitation in doing so? This is designed to not only protect the public at large, because it was my dad, but it could have been someone else, and he himself, his whole life is gone. He's going to be spending the rest of his life involuntarily committed. And that may not have been the only route for him. He was sick. He knew that he was sick. And it seems like he almost got approval for his decision-making, approval from the hospital, approval from the police that interacted with him twice and did nothing, on up until he executed the homicidal and suicidal tendencies that he let them know that he had when he started his voluntary commitment. So it's not just about my dad, although it is. We've lost two members of our family. Our family is wrecked. It's never going to be the same.
Yeah.
And so I would just like somebody to tell me what would be the hesitation in moving forward.
Yeah, no, I thank you, Mrs. Pride. I really appreciate you being here. And I think that's what we need to decide is what other states are doing, what are best practices. And I'd like to better understand if we can do this in a better way. And you and Delegate Cox have come up with a good solution. And I'd like to see that actually would make a difference to prevent something like this from happening again. And I really appreciate you sharing your story.
Thank you, Colin. I really appreciate this opportunity tremendously.
Thank you, Ms. Pride. Thank you, Delegate Cox, for bringing
this Delegate Hope. Appreciate your time and the committees.
Thank you. All right, members, why don't we move on then to the next bill? That's Senator Deeds' bill. Senator Deeds, are you?
Yeah, I'm here. Thank you. I think Channel 6 in Richmond did some reporting on that on the situation that surrounded the bill you just had a year or two ago, and you can probably look in the dial and their history somewhere and find it. This bill I'd almost forgotten about was a bill I introduced in 2020. It got through the Senate in modified form, was carried over in the House committee. This bill deals with a big issue that, even though the bill wasn't introduced till 2020, I've known about for a long time. The issue is, what do parents do to help their adult children who are mentally ill? And what we were trying to address in this bill was to give a parent the ability to have access to some information without a notarization. In the House, the Senate committee changed the bill to require that the person have no objection to a family member, or list a family member as someone who can have information to help that person. I introduced this bill specifically at the request of a friend of all of ours named Steve Pearson, and I think Steve's on the line. He can talk a little bit about why he wanted this bill to go in. But I'm not sure if this is the perfect solution, but I can tell you that this is a real problem.
Yeah.
What do you do about adult kids? Kids that are over 14 have a lot of liberty, but kids that are over 18 have complete liberty, and they're still your children, and they are. Sometimes they don't know what's best for them, and sometimes the parent, who might be the only person that provides them with sustenance and a place to sleep if they're not hospitalized, is cut completely out of the decision-making process. And this was just this bill was simply about allowing a family member to be involved in the information sharing process. If Steve's on the line, I'd appreciate it if you'd hear from him.
Yeah. Mr. Pearson, are you with us?
I am. Can you hear me?
Yep, we can hear you. Thank you. Thank you for being here.
Thank you, Mr. Chairman, for inviting me, and good afternoon to everybody. I'm here not in a lobbying capacity at all. I'm here in a personal capacity. And in a way, I really was struck by Ms. Pride's statement that the incident that family unfortunately suffered has ruined the family. And I think that nobody can be in the position of having a mentally ill child with a progressive disease that's serious and not wake up some nights and see that as their future. And if, God forbid, he ever did something like that young man did, it wouldn't just be his victim's life that ended. It wouldn't just be his life that ended. It would be mine. It would be his mother's. It would be aunts, uncles, cousins, and so on. Lots of folks care about my son. I'd like to think nobody more than me, but that's probably not true. But I care a lot about him. And I have tried through his experiences as an adult with the onset of this and the increasing severity of it to maintain a good personal relationship with him in such a way that he knew and knows that he can always count on me to try to help him and to shoot straight with him. I can tell you that he doesn't believe that the system shoots straight with him. I don't believe that the system shoots straight with me. And I'd like to change that and give the system and participants, involuntary participants in this, as I sort of am as well, along with my son, with the capacity to help, give them the opportunity to help. Because I think that the Commonwealth and family members of mentally ill people actually have a common interest here. What I have viewed through his process, through a couple of involuntary treatment, involuntary commitments now has been that opportunities are being missed to incent the patient into consenting to treatment. The code as it's written right now has lots of references to the patient will be provided with this information so that he can volunteer or she can volunteer or voluntarily commit themselves. But that doesn't happen. At least I don't believe that it happens. It certainly hasn't happened in my case. My son's been committed twice. The first time he tried to take drugs, I watched him take the drugs. He had some side effects, some anxiety-producing side effects that caused him to pace the room at night with his arms around his trunk. Because he was just, I don't know whether he's trying to stop himself from involuntarily moving or whether the feeling of anxiety was just so intense that he couldn't do anything else. But I've witnessed that. I've tried to get him to go back to doctors and see whether additional drugs could be administered to counteract the side effects or whether there were alternative drugs that could be administered that wouldn't have those side effects. He's not interested in that. And he's, as a practical matter, is no longer interested in any sort of antipsychotic and probably any sort of other drug. And yet, at every step along the way, when he has had to or when he was requested to, he's waived his HIPAA rights in favor of me and his mother. And that doesn't mean that we've been able to get anything from the system in time to use it. It means that we've been able to go to the hospital and request the documents through the bureaucratic system, pay for the documents, and get them 3 weeks later after he's been discharged. So I think it's a system that needs fixing. I think that family members and the Commonwealth do have a common interest in trying to fix it. And that's really what the deeds bill, Senate Bill 1049 from 2020, is really all about. It's a starting point. I'm not an expert in these systems. There are other people that are. And I think it's good that this bill is before you now. I hope that the subcommittee will choose to take a good, close look at this and at other creative ideas in terms of how you can incent these folks to get into treatment when a part of the disease is often a disbelief that they have a disease. So how do you deal with that other than trying to leverage them in one way or another into a situation in which it is to their advantage to consent to treatment? I think that's really what you have to do, and they can make an intelligent choice on that. I don't think my son, for example, is capable of balancing all of the ins and outs of medication administration, how often it's done, what the side effects are, how much he has to take, what other drugs he may have to take as a result. I don't think he's capable of doing all that, but I think he is capable of gauging his own self-interest. And if we make it in his self-interest to get treatment, then maybe that's a choice that he makes.
Okay. Thank you, Mr. Pearson. And thank you, Senator Deeds. Is there anyone on the committee that have any questions for either Senator Deeds or Mr. Pearson? Okay, not seeing or hearing any questions. Mr. Jackson, why don't we go out to the public? And again, I'll remind you, if you'd like to testify on this bill, please raise your hand so Mr. Jackson can identify you and bring you into the into the room with us to present testimony.
So we do have two members of the public who wish to speak. The first is Rhonda Thyssen. Give me a second, I'll bring her in.
Okay, Miss Thyssen, welcome back. Ms. Thyssen, are you there?
I am, thank you.
Hi, Rhonda,
good morning, or good afternoon, rather, Mr. Chairman and members of the committee. I just want to make a brief comment about this bill. Certainly understand and appreciate Senator Deeds and the prior speaker's perspective on this issue. It's really hard for family members of adults to, find information. HIPAA exists for a reason. I think what I really would like to say is that the utility of a bill like this is really going to have a lot to depend on how it's implemented, because I think we really need to acknowledge that, for as many folks like the speaker's son who are in need of support and assistance from their family members, we also have a lot of people with mental illness who come from families of origin that are damaging to them. They've experienced psychological trauma from childhood abuse. A lot of times that's related to their mental illness or their other behavioral health issue. And so I think we just need to keep that in mind when we're going down the road of further removing rights away from adults. Because, adults who have capacity should have the right to make decisions for themselves. And that also includes the right to invite in other parties like family members into their treatment process. Again, it's not a bad idea. I think it's a wonderful thing for people that need that. But there are going to be people for whom families are not the best people to be involved in their treatment because of previous history or family members' own mental health issue or, whatever the issue is. So I just wanted to bring that up as sort of the flip side of this. So thanks.
Thank you, Ms. Thyssen. Mr. Jackson?
We do have Jennifer Spangler.
Ms. Spangler?
Hello again. Thank you for giving me the time to speak. I am one of those people whose family is actually harmful. I'll just give 3 quick examples. I had a traumatic event as a 10-year-old occur. So if my family has reached out to, it's inappropriate because they were the ones who contributed to my actual mental health diagnosis. The second item is that when my family of origin knows about me being in a hospital, it creates more distress, and it also makes my recovery longer. And then just another thing I'd like to mention in general about involuntarily being committed, I can provide research to you with these points later, but involuntary commitment is seen as negative, and in 70% of young youth, so this would be 17 to 26, when they have those negative experiences, they lose trust in providers and parents and all that. So we just need to be very careful about how we're going about this, solving this issue. Thank you.
Thank you, Ms. Spangler. Mr. Bice, did you want to speak to the bill?
The only thought I had, I love the focus of it and appreciate the comments that have been made, but I wonder if it might be more appropriate to look at tinkering with the guardianship statutes and the definitions thereunder. I don't know, but I just put that out, and I'm sure that others have probably already considered that.
Yeah, Senator Deeds, did you want to speak to that? Because I just want to clarify that in your bill, I thought that the individual would allow someone else to be part of.
And that was a change made in the Senate bill, and that would have addressed, I think, that would address Steve Pearson's issue. If the individual would have to be identified and they would have to be their involvement would have to be approved. I think the issue Ms. Thyssen raised and was also addressed by Ms. Spangler was brought before the Senate committee, and that's why they changed the bill to require that the person be identified and approved before they be authorized. It would, the situation with my son, the situation was pretty similar to this. That would not have helped me. This bill would not have helped me, but it could help Steve Pearson. Steve Pearson's kids, I remember he was a great kid. He's a page of the Senate at one time. He's a great kid, a great young man. He's not a kid anymore.
Yeah.
But we have to help people be the best that they can be. And sometimes that means involving their family. But I think the issues raised by Ms. Thyssen and Ms. Spangler are legitimate. There are some times when families are the problem. And that's why the Senate changed the bill.
Right. Mr. Chairman.
Yeah, Senator Mason.
So, Senator Deeds, you're right. It sounds like the changes address that. The question I have would be, under duress, there would be a request saying, I've changed my mind. I don't want that family member anymore. How would we down the road ever be able to address that element?
Well, Senator Mason, I think the suggestion of Mr. Bice that we look at the guardianship statute makes perfect sense. When I started practicing law, establishing a guardianship was pretty damn easy. We changed the law 25 years ago, maybe 98, 99, 2000. In that period of time, Senator Gartland carried the bill that made the guardianship process a lot more complex, a lot more expensive. But the whole idea was to protect the person for whom the committee or guardianship is to be established. And in doing that, we made it more difficult for people who find themselves in a situation where they've got a family member that needs help quickly. It ain't going to happen through the guardianship process as it exists today. So that might be worth looking at.
Yeah, that's interesting. I mean, when someone, Senator Mason, to your point, when someone's in crisis, they could easily change their minds. But they are also in crisis.
Right.
And so maybe the guardianship is something that's a little bit more, can withstand that kind of change of mind so quickly.
Hey, Patrick, sorry, it's Nick.
Delegate Rush, yes, sir.
What folks who have gone through divorces, you see the guardian ad litem used where they're an advocate. The children have an advocate in the courtroom. What about something like that for folks who maybe they're not close to their family, or their family has different issues, maybe even substance abuse and other mental illnesses?
In the guardianship process, if that's what's to be tinkered with, there is a guardian ad litem typically appointed to represent the interests of the person for whom the guardianship is proposed. So, but further use of the guardian ad litem is worth looking at, I think.
And maybe we need to look at how we budget those things too, and make sure there's enough funds there so we have folks that are willing to take, attorneys that are willing to come and step in and take these jobs.
Yeah. Thank you, Delegate Rush. Delegate Watts.
Thank you, Mr. Chairman. I just wanted to come in at this point. The bill, as it was revised by the Senate, with the choice being made by the individual, and all of its details, which reflect Mr. Pearson's experience that 10 days later you get the information. So this inserts it at every single point. Needs to be hand in glove with looking at the guardianship situation, because I'm very concerned. That's why I decided to jump in, that there's abuse of the guardianship situation, particularly for vulnerable elderly, where a family member, for whatever reason, that person ends up in a situation where they become exploited by the guardian. So if a guardian arrangement is appropriate when it comes to the mental health concerns, I would suggest that you shape it for that and leave the guardianship protections of Senator Gartland in place for other situations.
Thank you, Delegate Watts.
Thank you.
Mr. Jackson, is there
Mr.
another speaker?
Mr. Chairman, yes, there is one person in the attendee waiting room who would like to speak, if possible.
All right.
Anna Mendez, I'm promoting her to panelist right now.
Ms. Mendez, I'll call on you, and then after that, I'll call on Jennifer Faison. Ms. Mendez, welcome.
Good afternoon. Thank you, everyone, for allowing me to speak. My name is Anna Mendez. I'm the Executive Director of Partner for Mental Health in Charlottesville. I wanted to jump in really quickly and make a comment about guardianship. We certainly can echo the experience of Mr. Pearson of having family members who are not, I think the term he used was, the system is not shooting straight with them. You know, their loved one has signed a release of information. The system expects them as the family members to provide health insurance, to be the responsible financial party, to make sure that the person is getting to all of their appointments. We expect the family member to provide housing. But then when the family member goes to advocate for the stated wishes of their loved one, the system is less inclined to appreciate that type of interaction. So I absolutely want to echo that. As an advocacy organization, we are seeing and hearing reports that support what has happened to Mr. Pearson and his family. And we also feel that that is a very long way away from needing to increase access to guardianship, which is a situation in which a person effectively becomes like a child. I mean, they can't contract. They can't have a driver's license. They can't, there's all kinds of things. You essentially have very limited rights. And so especially since Senator Deeds' bill had been amended to reflect that the collaboration with this family member was with the consent and support of the individual experiencing the mental health crisis, we would encourage the committee to move forward with reintroducing the bill as it was amended, rather than look to solve this problem by expanding guardianship. I think psychiatric advance directives could also have some type of role in this situation. And I know Dr. Zell is here, and that is definitely her area of expertise. So if she wants to speak to that, I will stop speaking.
No, thank you, Ms. Mendez. That was very helpful. Ms. Faison?
Hi, good afternoon, members of the committee. Mr. Chairman, Jennifer Faison with the Virginia Association of Community Services Boards. I wanted to just remind folks that the advance directive is a very powerful tool, especially the way that we have it crafted in Virginia, because it does have that Ulysses clause in it, which would allow for those instances when an individual is in crisis, if they have indicated in their advance directive that they would like for that family member to continue to participate, even if they are saying in that moment of crisis that they no longer want that to happen. It can still happen with the legal instrument that we have in place through the advance directive. And so, I would challenge the Commonwealth to find ways to help families navigate the advance directive, to help advertise that there is this document that takes all of the decision making out of that moment of crisis and backs it way up to where the individual and the family members who wish to be involved can really walk through all of the treatment options and things like that. So I think I would just challenge us to be creative in our thinking about how we can really make sure that the advance directive becomes the primary vehicle for problem solving for these families. So we're not waiting until that moment.
Okay, that's a good point. Thank you, Ms. Faison. Dr. Zell, did you want to weigh in?
Yes, I just, Anna Mendez and Ms. Faison, they've both already said sort of what I would say. So I'll just indicate that, yes, I agree. I think advanced directives as an excellent intermediate tool that Virginia has done a nice job crafting, and we just could be doing more to make use of those to, again, not address every situation, but some of these situations would be well addressed, I think, by an advanced directive.
Thank you, Dr. Zell. Ms. Daly, did you want to weigh in?
Yes, just very quickly I want to reiterate, as some of the other commentators has mentioned, that it is actually a guardianship is a significantly greater intrusion on a person's individual liberties. And so I definitely think that's not a thing you want to expand without giving it a lot of thought. But I would also just suggest that really does put a person in a kind of adversarial relationship with family members in a way that may be a bit inappropriate and maybe damaging to those relationships. And so that's something also to be thought about. And then, I'll just say with respect to advanced directives, I also think that can be a very good solution. And I know that Virginia has put a lot of effort into, really making that available as a resource. And I'll just mention that, anecdotally, what I have kind of heard about that as a solution is that it's not given as much effect on the medical side as you might hope for, which may just be a training issue. I mean, it may be just an issue of making sure that medical professionals and hospitals are aware that they are supposed to give legal effect to that. But I have heard that, there is sort of a gap between what the legislature has put forward as a solution and what actually is given effect as a solution in the real world that we should probably be thinking about and moving forward.
Okay, thank you, Staley. Anyone else wish to be heard on the bill? Senator Deeds, did you want to have any closing comments? I don't know. It sounded a little like to me that there was some consensus around the advanced directive, although I think we need to make sure that the current law for the use of that tool is something that's flexible enough to impact these cases.
I think enough has been said, and I agree the guardianship would put family members in adverse positions, and that should only be used rarely. I still think that's something that probably ought to be looked at if we can make better use of that in a mental illness situation. And I agree with Delegate Watts to a large extent. That was changed primarily because of concerns about the growing abuse of elders. But I appreciate your time very much this afternoon. Appreciate this.
Thank you, Senator Deeds. Mr. Pearson, did you want to say anything closing before we move on as well?
Thank you, Mr. Chairman.
Yeah, go ahead, Steve. Yeah.
I've been listening with great interest to the discussion, and it's very pleasing that it seems to be heading in the right direction. The one thing that I would urge you to do is don't forget the mandatory treatment aspect of this, and because so many of these people believe as a part of their illness that they are not ill, and therefore will resist treatment when they can. And I think I've got one that has actually earned it, because he did take treatment for a while and it didn't work for him. So just please don't forget that. That's all I have.
Yeah, no, thank you, Mr. Pearson. All right. Thanks, everyone. And thank you, Senator Deeds. Let's go ahead and continue on with the next item on the agenda, and that is about the reorganization of the statutes governing mandatory outpatient treatment. And we have a number of stakeholders that have been involved in some of the policy changes that we undertook last session. But there's at least a consensus clearly from a lot of folks that it needs to be organized in a better way. And so what we want to do is we want to certainly take that on during this off session, have this work group help with that. And so we have a number of folks here that want to speak to testify in favor of taking that on. And I have Dr. Zell, Lisa Daly, David Bryce, Kathy Harkey, and Anna Mendez here. I don't know if there's anyone else that wants to testify, but those that are here, why don't we go ahead and call you and Dr. Heather Zell. I'll start with you. And then for others that are in the public, we'll ask them to come in at that time. So Dr. Heather Zell, you were recognized, and thank you for being here.
Thank you for having me, allowing me to provide some input. And my aim is to keep my points sort of shorter and overarching. Ms. Daly and Mr. Bice, who, we did some drafting on ourselves and have spent some time. And I think I'm looking forward to their input as well in terms of what they took away from that experience. But I think, just to take the step back and reflect on the time that we spent with the statutes and sort of there's this sense of, we'd go in and you look at it and it seems like you've got everything pinned down. And then the next day you look at it and the very same, a very same provision might suddenly read sort of differently. And it kind of comes down to, I think, in a sense, sort of the story of just that mandatory outpatient treatment was first interwoven sort of in a minimal way, just the idea that it was there into the existing statute 37.2-817. And over time, though, as Virginia recognized the need to refine and give additional details about how this is going to work, weaving all of those things in just got unwieldy for the idea of integrating it into the existing involuntary inpatient kind of commitment statute. At first, it seemed like it was helpful there, perhaps because it was sort of just this, option B, but it's really MOT itself, mandatory outpatient treatment itself, has a lot of moving parts, which are good because it allows it to be this more malleable or flexible sort of mechanism that can meet folks hopefully where they're at, so that we've got a more outpatient oriented approach for individuals for whom it might fit. But it does have different standards, different timeframes and timelines, criteria, different roles and mechanisms that all sort of build on each other, but have slight variations. And so it makes it ripe for some confusion. And even, I think, doing very good, effective drafting that's sort of efficient ends up using a lot of cross-references to different criteria that can easily introduce an actual incorrect sort of reference to a criteria. For example, the idea of being discharged to MOT in the previous statute, it sort of was referring to criteria at the outset as if somebody was meeting inpatient criteria. So you had this sort of conflicting sense that just made it difficult to follow the thread through all of the sections and subsections. I'll just take a quick note here. So I think the other sort of overarching thing that I'll add at this point is just that because there are these many moving parts and there's different parameters and procedures depending on what type of MOT at what point in somebody's trajectory, it would be more helpful to sort of step back and just take a chunk by chunk, like let's look at the procedures, let's look at the who does what kind of thing, instead of trying to keep it all woven together, because even if it's woven together correctly, you just have a lot of insertions and additions along the way that kind of break up a paragraph here and there and make it hard to follow what is laid out. So I think I'll pause there with those sort of overarching comments.
Okay, thank you, Dr. Zell. It's probably led to a lot of confusion that CSBs and judges and whatnot have seen in the statute. So Lisa Daly's here, also a Treatment Advocacy Center. Ms. Daly, thank you for being here. You're welcome.
Thank you. And first, I want to thank everyone for this monumental legislation having been passed. I know it was kind of a long road. It was a lengthy process, a lot of stakeholders involved. And I do feel that the current legislation, as passed, really does fix a lot of the issues that we identified as being barriers to having the law implemented in Virginia. But I would agree that it does continue to be a confusing statute that is difficult to sort of place yourself within as a practitioner and kind of follow it as a continuum, the way that it is meant to be implemented. So I would agree that there are probably ways that the law as passed with the substance basically having been properly worked out could be organized in a way that would be easier to follow. And, sort of as part of our look at this initially involved speaking with a lot of CSB practitioners and speaking with special justices. And really the one thing that everybody agreed on is that the statute is really confusing and it's very kind of difficult to figure out exactly where you are with it and, what part of this am I in? Am I following the procedures? There was an issue with initially the two different types of MOT. There's more than two, but the two that are the most similar having different criteria, which we have actually fixed and ironed out at this point. So I definitely would encourage, continuing with the process of making sure that the work that we've done to substantively change the meaning of the MOT statute could also lead to an organization that makes it easier to implement, because our goal is to see more use of the MOT statute so that more people can receive treatment on an outpatient basis if they're able to do so. And I do think that there are ways that it could be organized that would make it a little bit easier to do that. And then I would also just like to add that, one of the themes that I think has come up a lot today is the need to train the different practitioners and stakeholders as to what these criteria are and what the process is, because we do find that there's quite a bit of disconnect between the individuals who are lay people who are making a decision about whether or not somebody meets criteria, and physicians and social workers and CSBs and what have you. And it really is a great opportunity right now, since we are going to be in a position where we're going to be, restructuring things and looking at whether or not there's a better way to lay this out. This would be an excellent opportunity for us to really invest in ensuring that the different people who need to understand this process and really know what the legislature intends with these criteria can receive the guidance that they need so that this is carried out in the way that it should be, because we are finding that there are significant disconnects between how it is interpreted in one place versus another, or in one role versus another. And the idea obviously should always be that a person is subject to the criteria in the same way, in the same part of the state, regardless. So basically, if you are in Arlington, you should have these criteria applied in the same way that you would be in any other part of Virginia. And I think this would be a great opportunity to really invest in that. Virginia has done a lot of work in the last several years to try to improve your mental health delivery system. And this would be a great opportunity for us to ensure that we've really given all of the practitioners the information that they need to do that.
Thank you, Ms. Daly. David Bice is next. Mr. Bice, welcome.
Thank you, Delegate Hope. I really am going to limit my comments to just saying that I echo the sentiments of Dr. Zell and Ms. Daly. As a special justice, I've been asked to train the special justices across the state by the Office of the Executive Secretary for the last 12 years, 14 years. And the single most difficult subject area when I'm training the special justices is the mandatory outpatient treatment section, simply because when I have the statute up on the screen, I've got to switch back and forth between so many pages. And the confusion that results, I just wonder, I think the overall objective is to see this process used more often. It's less intrusive, and it does encourage independence on the part of the individuals under treatment. But if the process is so confusing that the judges don't completely grasp how to use it, then that has to affect how often it's implemented. So I would encourage that we continue in the process. Thank you.
Thank you, Mr. Bice. Next is Kathy Harkey from NAMI, Virginia.
Yes, good afternoon. It's a pleasure to be with you all today.
Thank you. Welcome.
Thank you. And I'm going through my notes to speak about this issue. Again, like Mr. Bice, what Lisa Daly have said and Dr. Zeal have said really are about the same as what I would have to comment. But I would just like to add my support of this as an option to support wellness. It has been an underutilized option because it wasn't workable or used often the way it was set up previously. And a lot of work has gone into this through the recent committee that just wrapped up the spring of last year. I joined NAMI Virginia and participated on that committee towards the end. So I wasn't quite as involved as Lisa Daly. Since that time, and the other committee members, but since that time, I have read all of the information and studied it to see what issues might need to be addressed. And I agree, due to the complexity of this, breaking it down piece by piece, I think would help with providing people with what they need, the information that they need, and the easiness of use to understand this a little bit better. But this is an outstanding option. Throughout today, I knew that we would be speaking on MOT. And so I've listened to other people testify, and I've heard that inpatient commitment can create a problem. It can be traumatic. This can serve as an option to that. However, when that is needed, this can serve as an accompaniment to it. And so it is a viable option that I feel like we need to work through any little glitches in understanding or use of the law to where this is a tool that we can have in the state of Virginia. So I would truly like to see more use of this in the statute, and I think that breaking this down and working out the different aspects of it piece by piece is a good option to move forward.
Thank you, Ms. Harkey. Thank you for your testimony. Ana Mendez from Partners for Mental Health is here. Ms. Mendez.
Thank you very much, Delegate Hopen. Thank you for taking this on. I think mandatory outpatient treatment is the topic that perhaps has been neglected as long as it has been, because it's the topic that you can make everyone angry at you for trying to make better. Please, committee, please reorganize the statute around mandatory outpatient treatment. The current structure of this statute is unnecessarily complicated and unclear. And there are two really terrible outcomes from this lack of clarity. The first is that individuals can't tell if their rights are being respected, because you can't follow a thread, as Dr. Zell said. And the second is that family members and supporters, they really can't tell if their loved one actually meets criteria for MOT, because again, you can't follow the thread. So if for no other reason than that, this statute really needs to be reorganized. Additionally, an outcome at Partner for Mental Health, we would hope that an outcome of reorganizing the statute is to clarify that this thing that we singularly refer to as MOT is actually at least two very distinctive entities. And this is where Senator Mason tells me I swing from one side of the pendulum to another. So I'm going to work to be really clear here. On one end of the pendulum, what we call MOT right now is a way to prevent involuntary hospitalization for a person who, in this current moment, meets criteria for being hospitalized over their objection. So that is one side of this thing that we call MOT. But the statute also right now refers to something else as MOT, and that is a mandatory intervention for someone who does not in this moment currently meet the criteria for inpatient involuntary commitment. And because of challenges in the structure of Virginia's mental health service system, may or may not be able to easily access voluntary care if they were to request it. And right now we refer to MOT as just that one singular thing, when in reality it's two very different things. And reorganizing it would be a really strong way to make it clear that we are talking about two different things. The third and final thing that I'll say is that reorganization alone is going to be insufficient to more robustly utilize MOT to avoid involuntary hospitalization. Our community services boards, and as I'm hearing from Mr. Bice, our special justices, are going to need trainings similar to kind of the ECO, TDO, ES modules that we make our pre-screeners go through. In addition to having that training, we are also going to need to create and by we, I mean you, the General Assembly, are going to need to create the expectation that mandatory outpatient treatment is utilized as necessary when it is a viable and safe alternative to what would otherwise be an involuntary inpatient hospitalization. Thank you very much for your time.
Thank you so much, Ms. Mendez. That's all the speakers that we have lined up, although members of the public are welcome. So I'll call on Mr. Jackson now to see if anyone is interested in weighing in on this topic. Please raise your hand so Mr. Jackson can recognize you and bring you into our room, wherever we are, whatever you call it.
Mr. Chairman, we have 4 people who wish to speak. The first one, I'm going to list them all before I move on. We have Rhonda Thyssen, who I believe is already in the room. There she is. And we also have Jennifer Spangler, Edmund Creekmore, and Bruce Cruiser. So if Rhonda Thyssen can speak, I will bring the others into the room and announce them when she's done.
Hi, thank you again. This is Rhonda Thyssen. I believe I neglected to mention when I spoke before that I'm representing the Disability Law Center of Virginia. We brought up our concerns about the text of the bill and the removal of the individual's agreement with the process during the session. We just want to reiterate again, cooperation from the individual who's subject to the order is really critical. I mean, the agreement of anyone who it wants to achieve long-term success of treatment and, their goal is recovery, right? I mean, involving people in a system and a process that they are actually consenting to as opposed to opposing is way more likely to get better outcomes. We would like to see reform of this statute in a couple of different ways. One in particular, we really support including a specific and required role for peer supporters in any court-ordered treatment process. This would better encourage, involvement and cooperation of the individual who's the subject of the order. Peer supporters, especially peer supporters who may have been themselves subject to an MOT order in the past and can help the person understand, what it is that they need to go through, what do they need to do to sort of adhere to the order, to the spirit of the order. And we also would encourage the language of the statute to be changed to something something like court-assisted treatment or court-supervised treatment. And, that sounds like semantics, but when we talk about mandatory treatment for people for whom previous experiences with mandatory treatment can include, hospitalization in which they were involuntary committed and their rights were taken away from them. The language that we use, I think, is really important. So we would really like to see, a little bit more focus on the not only just the needs of the person, but on their agreement in the process. And because again, it's like the goal is recovery, and people can't be made to recover. They have to be willing and interested and actually want to recover. So thank you.
Thank you, Ms. Thiessen. Ms. Spangler next. Ms. Spangler, welcome back.
Thank you. Regarding this subject, I'd just like to mention, you've been discussing about how MOT is definitely less intrusive. And I'd just like to point out that, and correct me if I've got the bill or law incorrect, but it says that you can be in MOT for 6 months with one option to amend or rescind the order. And if I personally was given the choice, and obviously if I was in my right mind, I would choose hospitalization, because I would have 1 week of treatment and then I'd be discharged to my outpatient therapy. And then I'd also like to mention that I have never found outpatient services in that way to be helpful. When I had them following inpatient hospitalization when I was first diagnosed, I did not receive any tools that helped me. I've received all of the tools that have helped me cope from the community. And so I would much rather we invest in community services as a way to have outpatient therapy. And then last, to the woman from DLCV, I would just like to say that the fact that I get to choose, it really matters, because I only know what a medication is doing to my body. This is a mind disease, and other people only know what's happening in my mind because I tell them. So like if I'm having a problem with a drug or, all these different things, I'm the only one who knows that. And unless you're listening to me and giving me multiple chances, especially when it's a new cocktail, right? It takes time. So those are just my thoughts on this matter. Thank you.
Thank you so much, Ms. Spangler. Who's the next speaker, Mr. Jackson?
Edmund Creekmore.
Mr. Creekmore, thank you for being here. Would you like to speak to the reorganization topic? Mr. Creekmore, are you there? Is he in the room, Mr. Jackson?
He is in the room, asking him to unmute, but if he can hold on, we can go to Bruce Cruiser.
Mr. Cruiser?
Yes.
Mr. Cruiser, is that you?
Yes.
You're recognized. Thank you. Yes, sir.
All right. Yes. Thank you, Mr. Chairman, members of the committee. I'll keep this short. Yes, please rewrite it. For all the reasons that have been stated before, we would agree, without taking a position on the content of MOT. The reality is it's hard to do that unless one can really understand what it does and when it applies and how it applies. So all the stakeholders that I've talked to have agreed that, yes, please help us understand it. And I think this is the way to go. So thank you.
Thank you, Mr. Cruiser.
And it appears that Mr. Creekmore has unmuted himself.
Mr. Creekmore?
Yes. Can you hear me?
Yes, sir. Welcome.
Yes. Thank you very much. I appreciate being given the opportunity to reappear before the committee. I am very interested in changes that may help to simplify 37.2-817. I have a particular interest in what's called therapeutic jurisprudence. I am very much a believer that the civil courts could function, including the commitment courts, and the MOT dockets could perhaps function more as the mental health dockets in the criminal court system, but without the criminality. It seems to me that with several modest changes made to 37.2817, we could revise the statutes in a way that would allow us to produce the equivalent of a mental health docket. Some of the changes that I would like the committee to consider would be Mr. Adams' House Bill 1026 that proposes dropping the 3-year, 2 unsuccessful, I would consider them unsuccessful if they come back on an involuntary commitment, to drop that provision and to give the patient more choice and the judge more broad discretion in revisiting the issue as to whether the options being considered should be for the patient to participate voluntarily in an MOT order, as was previously the case in the code before it was recently revised, but to give the judge broad discretion if by the patient's choice they are not able to abide by a voluntary commitment order, then to revisit that issue later on through the judicial review and the judicial status hearings that are being suggested, I think primarily on site at the CSBs, if I'm understanding the practical implementation of 37.2817, to give the judge that option if the patient is on the basis of the recommendation of the CSB treatment team and the attending physician to be ordered on an involuntary basis into mandatory outpatient. I think that this could be further facilitated if we revisit another issue, which is extending the current statute that only allows for 72 hours for the independent examiner and the attending physician to do the requisite competency assessment. Currently, under the code, there is an allowance if the court hearing falls on a state holiday or on the weekend, that the patient's waiting period prior to the TDO could be extended to 96 hours. I would like to propose that be made permanent to 96 hours. That would give people like me who are independent examiners more time to work with the doctors. I think it could involve, since it is a judicial proceeding, the judge could have the discretion to allow responsible family members, not all family members, but if the judge had the discretion to allow family members to participate in the hearings, that would be a way to allow family to have some input into the process and at the same time respect the patient's rights of due process. I think with a system like this, with the judge having the discretion to order voluntary or involuntary, depending on the observed history following the initial TDO, and I think this would allow a record trail. If we drop the 3-year period, Lord only knows where we're going to get the records to determine whether the patient has been non-compliant. The patient could come from out of state, could have been sent to another hospital. I think if we make this begin at the initial TDO and track the patient's progress from that point in all instances, then that makes it more possible for the TDO judge to have some options that could work in favor of the patients choosing on a voluntary basis to participate in treatment. And then if it doesn't work out, to come back and take a second look.
Okay. Thank you, Mr. Creekmore. Appreciate your testimony. Mr. Jackson, is there anyone else from the public that wanted to be heard?
Mr. Chairman, that was the last speaker.
Okay, thank you, sir. Is there anyone from the commission, the work group, wants to have any questions? Okay, not hearing any. Let's go ahead and then move on to the next topic, which is public comment. And is there anyone from the public who wishes to speak more generally about any topics, Mr. Jackson? And please, again, raise your hand if you have any public comment that you want to share with the work group, beyond what maybe has already been shared.
Mr. Chairman, there are no hands raised.
Okay. So then let's go ahead and go to the next topic. And actually, we could probably combine the discussion and the directions to staff. And so what we did was we heard a couple of bills here. And then, of course, we heard some discussion around the reorganization. Why don't we go ahead and discuss the first bill, which was Delegate Cox's bill, about what next steps we ought to take and maybe any direction to staff. Does anyone have any thoughts on how we should proceed with that?
Hey, Mr. Chairman, Delegate Rush.
Yeah, Delegate Rush.
Yeah, I actually thought Delegate Cox's bill was trying to address a problem, but I think, like the chairman of the work group, I'd like to see staff maybe pull up some things that other folks are doing in other states. I'm not sure if we need a second psychiatrist. So maybe the current system of administration signing off on it, or maybe go back to the magistrate or whoever did the TDO. But we probably do need to look at something in this arena where we're not just letting somebody with very little oversight let somebody out early. And for draft, you're going to have bad results, even if it's just to the individual or to someone else.
Yeah. Ms. Stanton, is there a way that we can, and it's maybe something Ms. Daly can help us with, or maybe NAMI Virginia can help us with, is see what other states are doing in this area and make sure that we're not an outlier. I'm not convinced that having a second layer would even have solved this problem. The individual might have been released. We'll never, of course, know, but I certainly want to be in line with what best practices are. What do you think, Ms. Stan?
Yes, Delegate Hope, we can definitely do that. I can reach out to both of the individuals you've mentioned. Plus, we routinely do 50-state surveys here at DLS and pull information like that together. It's certainly not a challenge.
Oh, great. Well, I think that's probably the best way then to procead.
Yeah, Mr. Chairman.
Yes, Senator Mason.
I agree with that, looking at that, because, what a horrible and egregious circumstance, right? But that jumped out at me like the old days from courts of justice, that you had one really horrible circumstance. So we jumped to try to make a change and adjust something based on it, and was something just wrong, or, we are taking a great deal of effort to try to discharge people from hospitals, certainly not under this situation like that. But, it just, as I heard that horrible circumstance, it just made me wonder whether a reaction to it was something that we often try to avoid in terrible situations like that.
Yeah.
I totally agree, Mr. Chairman. I think a survey of the 50 states or the 49, and then maybe figure out where we're at and see if there's a way to tweak that bill or come up with something different.
Yeah. Delegate Watts.
Thank you, Mr. Chairman. And this is a comment from sort of a 20,000 foot level, not 30,000, 20,000 foot level. We have had a problem, and it's in several other bills, and the subcommittee that I will chair on will be following up on the court proceedings where someone's mental history is brought into a criminal charge, and looking at those circumstances. We've had, since Virginia Tech and we first got into this, a real problem of immediate danger to self or others, as opposed to bringing in history of the individual. And some of what was talked about in discussing this was whether or not the Community Services Board, with their knowledge of the individual, whether or not the magistrate, who supposedly had a fuller hearing than the quick review in the release decision. All of those things are, I think, elements of should we be looking at what other states do on defining our standard of immediate danger to self or others, because an appropriate review is not always being conducted at several stages.
Yeah. Okay. Ms. Daly, did you want to offer something? I was initially was thinking this would be just between the work group, but is there something that you wanted to add that would be helpful? I actually invoked your organization's name in helping us do this.
I actually just wanted to just request that we be sure that we include the medical community in this problem-solving approach moving forward, because it occurred to me that in the course of our very lengthy MOT work group, that was a group that was not represented. We've had trouble engaging the medical community and in some of these issues, and we can't solve this without them. So I just would encourage everyone to make sure that we find a way to engage them.
Good point. Good point. Any other discussion? I think, Sarah, does that give you some pretty good direction on what our next steps ought to be for this bill? All right, then why don't we go ahead and move on to the next bill, Senator Deed's bill, Senate Bill 1049. I thought that we were getting some consensus around taking a look at advanced medical directives, and I don't know if taking a look at that statute to determine whether or not that is sufficient to deal with this issue, or there also seemed to be some consensus, at least early on in our discussion, from a lot of the different advocacy groups, that the amendment that what happened in the Senate with Senator Deed's bill, in other words, to give the express consent of the individual, was also adequate as well to deal with this issue. Are any thoughts from other members about our approach to Senator Deed's bill?
Well, Mr. Chairman, I wanted to point out that came out unanimously, but not on the unanimous docket. So that means that was definitely debated and discussed, because there were abstentions in the committee for the Senate. So certainly allowing the person to agree to it assuage the concerns of the Senate. In our conversation, it seemed, I thought we were going down the guardianship path early, and then that kind of seemed to say there were some issues associated with that. But then I think down the stretch, when someone pointed out that maybe the advanced directives aren't having the weight that we think they have, intent for them to have, mean for them to have, that certainly if we couple those two things, maybe we get to where we're trying to go.
Yeah. I mean, what I don't know the answer to is under the current statute that deals with advanced directives, is that sufficient enough to deal, or does it need work? And is that a better approach than what Senator Deeds had proposed in his bill? Delegate Watts, did you want to get in?
Sorry, I have hit all these buttons.
No.
I think I heard your question, Mr. Chairman. I align myself with what I think I heard Senator Mason say, is that the two things need to be done. Whether or not the advanced directive needs to be strengthened so that it is used more effectively. And I really noted all of the stages that were in Senator Deed's bill, where once you have the patient's consent, the information will be conveyed. That's the key thing at each and every one of these stages. Not a different proceeding to get it, but it will be conveyed. And that, I thought, was at the heart of what Mr. Pearson said, that you might get it at one point on one hearing 10 days later.
Right.
That's not the effective approach.
That's right. Dr. Zell, did you want to jump in?
Yes, and recognizing that this is really between committee members, I just want to note again that the Institute of Law, Psychiatry, and Public Policy worked with the Department of Behavioral Health for several years on trying to expand use and recognition of advanced directives for psychiatric considerations or planning ahead. And we'd be happy to talk more about it. Off the top of my head, I think the statute might be in good form. It's just that it's the implementation and getting it utilized where there's some lost ground.
Yeah. All right, thank you. Ms. Stanton, I think we sort of have different issues here, different solutions, but do we need, are we have some leeway to have another hearing? Do we need more testimony on the best approach here? Or do you have any advice for us to how to proceed? I mean, it's clear Senator Deeds has brought a problem before us. He had a way to solve it. There are different ideas here that are being bandied about of whether there might be other better ways to solve it as well too. But the problem does need to be solved, and I'm trying to figure out what's the best way to solve it.
Yes, Mr. Chair. I think there are a couple of things we could do. The advanced directive statute is pretty clear on this topic, but as Dr. Zell pointed out, there are sort of consistent issues around making sure that people are completing an advanced directive, making sure that's in place to begin with, and then how those are honored. We could take a look at some of the guardianship options as well. I would point out that one thing that's gotten lost a bit in this discussion, I think that came up during the testimony on this bill 2 years ago, was that you have a gap that this bill, I believe, was intending to address, which is a person who has not executed an advanced directive prior to the situation in which the information sharing might need to happen. So advanced directives, guardianships, those are things that either take time or you do prior to a crisis. But for a person in crisis, there was a question also as to how, HIPAA permission to disclose under HIPAA might fall into that. So the larger subcommittee had a discussion around HIPAA rules, and that may be something we want to look at as well. Advanced directive helps if somebody has executed one prior to the crisis, but if they executed the advanced directive, it doesn't help.
Yeah.
Be a piece we want to pursue as well.
Yeah. So do you think that we could look at this and have another hearing on this? Okay, so clearly there's a problem here that needs to be addressed. We probably need a little bit more expertise to help us figure out, and there's different levers I think we need to tug on to get at this. All right, any other discussion on this bill before we move on? All right, so let's bring up the reorganization topic. I mean, I think I heard consensus from everyone that testified that we need to reorganize the statute. I didn't hear any dissent. Some people brought up some other areas that they would be interested in more policy changes. That wasn't necessarily the focus of what the work group was going to do, is to do any policy changes. But I would ask that if folks do have some policy changes, then maybe if we can get those in writing. And so for those, the public that are still listening on, if they have some specific policy changes that they'd like to see, I wouldn't mind seeing if we can find some consensus in order to do that. Again, that wasn't necessarily the charge of our work group is to change any policy on this, because I know that this had been what the policy that had been before you with the bill that we passed last session was under a lot of different scrutiny and had several years worth of discussion and back and forth. And it was very carefully crafted in order to get to the point where it was. But I think if there are some things that we can do to find some consensus, I certainly wouldn't be closed to that. However, our task was to do the reorganization. And so it was very clear to me that people are a resounding yes to do the reorganization. I did hear a lot of discussion around training as well, too. That probably takes funding in order to do the training. I don't know if there's stuff that can be sort of taken out of a box and used, but there might be something that we would have to bring back to the full Deeds Commission to recognize perhaps some budget money to do some training in this area. But in terms of the reorganization, I think that was a yes. Did anyone felt any differently about this task? And my thought in terms of proceeding is Ms. Stanton, is to take the first stab at it and share it with the folks that have testified, and then bring it back to make it public, of course, and then let's discuss whether or not we're on the right track. Does that make sense?
Yeah, it does. Also might be helpful. I'm trying to think of the way to manage that. We might want to set up a working group to go through the drafts and that type of thing, because it's going to be a very lengthy and detailed process. And we're going to have to take into account the changes made last year. So there'll be a lot of just really technical detail work that's going to have to happen. So we may want to think about setting up a working group to come through some of those pieces. There'll be a lot of questions that need to be answered in the drafting of it as well. So you may want to take that into account as we move forward.
Okay. And what's the process for creating for a work group to create a work group?
What we could do is probably identify some stakeholders who might want to be part of that process, and we can go through as a separate working group. We would, of course, report back regularly to this group to make sure any decisions being made, any actions being taken are consistent with what you're looking for. But there will be a lot of communication around that process.
All right. That's good. So why don't we put something together? It could look very similar to what we heard in testimony today. Mr. Jackson, I see your hand raised. Is someone from the...
Yes, sir. Mr. Chairman, I apologize. I just wanted to make you aware. I'm not sure if you're taking any more testimony, but there is someone in attendance who would like to speak.
Okay.
Mr. Edmund Creekmore, if you're...
Well, Mr. Chairman.
Senator Mason?
I was just going to say that Mr. Creekmore has provided us very detailed suggestions and previous testimony, and maybe we could go through his suggestions, because he have some policy changes, try to sift out just a few, like boil it down from 10 documents to maybe 5 bullets that he suggests as a change. Yeah. And as you said, that's not the reorganization charge, but that could be considered an adjunct with the reorganization effort.
Yeah, I agree with you. Let's, and I'm not for just Mr. Creekmore, for everyone that have some substantive changes, policy changes that they would like to see, I'd ask you to put them in writing so that we can consider if that's something. And again, I want to see if we can find some consensus in doing that. I mean, we certainly have our hands full during the off season with the bills that we brought. And again, we've got Delegate Adams has a bill that we're also going to have to hear at a later date. That with the reorganization is going to be quite a bit of work. So if there are some things that we can find some consensus, I'm all for it. But if there are things that are going to be much more challenging and difficult, I think we're going to have to put them off. So sure. I would ask everyone to put their changes in writing, if they would, for us to consider. Senator Mason, did you want to?
Well, when we're done with this, Mr. Chairman, I have another entire topic that I'd like to share with you that's not small.
Okay. You have the floor.
So, because that's quite an undertaking right there and super important. I think one of the people that testified said it best. We want to use it in as many circumstances as we can quickly and in ways that it applies. So hopefully reorganization will help us there. Mr. Chairman, tomorrow, as you know, we're meeting to discuss law enforcement emergency room effort that we are trying to tackle. And from discussions that I've had surrounding that, really another issue has bubbled in. It's working our way back to the reason that there are no beds involved and available, rather. And we know from 2017 to 18, admissions total at Eastern State almost doubled. And 17 to 19, they did double, just admissions in its entirety. But one thing that's jumped to the fore, Mr. Chairman and members, is that about 50% of these are forensic admissions. So they are being sent because they're emergency TDOs, criminal TDOs, or incapable of standing trial. And about 60% of them are being admitted for competency restoration. And so it turns out that we're not the only one. Of course, there's what we're calling a competency crisis across the nation. But from 2011 to 2019, forensic submissions statewide more than doubled. And so Eastern State particularly, Mr. Chairman, about 35 to 40% of these are misdemeanor charges. And so in a lot of places, we are sending these forensic cases to Eastern, which because of code, as I understand it, bumped and take priority. So they're filled first. We're getting people in and out at an average of 52 days at Eastern, better than the system average of 76, but sending them back to jail or to court to stand trial.
Yeah.
And in some cases, they're trespassing, shoplifting, petty larceny. And by the time they get back and go through it, the sentence would have been much shorter than the process that they're going through. And so I just spoke to an emergency room doctor this morning. There are 14 people at Norfolk General this morning awaiting a mental health and behavioral health bed or evaluation. And so over the time we're having so many of these forensic admissions that a lot of the civil cases are not even being able to be heard or to get there. And so I don't know to what extent, I'm fairly new to the commission, so I don't know to what extent we have studied this competency crisis and this forensic admission effort, or just data, stats, and information in Virginia. But I just wanted to raise it because it seems like this committee, not the one tomorrow, it would be the subcommittee to review it. And I just wanted to bring that up and say that, we're making a great effort at jail diversion, but most of that seems to start at jail. And we really seem to have a pre-trial scenario issue challenge before us that I think, Mr. Chairman, this committee should seriously think about evaluating and discussing.
Yeah. Now, my question is whether or not we shouldn't create a new committee, and that's obviously the Deeds Commission can do that. Delegate Watts.
Yeah, the committee that I chair morphed from the Law Enforcement Criminal Justice Committee. It's now called Special Populations, but I really believe that it still has that original heritage of how people move through our quote unquote justice system. And so I believe that what Senator Mason has raised properly goes before what is now called the Special Populations Subcommittee.
And that's the one that you chair, Delegate Watts?
One that I chair, yeah. And again, have served on it a long time, so know all of the diversion things that, as Senator Mason referred to, that we have started trying to divert people from the justice system. But when they end up in the justice system, he's bringing up a major problem that is occurring that is separate from what's happening in the jails.
Okay, yeah. Heidi Dix, I see your hand is raised. Did you want to jump into this discussion?
Yes, thank you. I just wanted to chime in and say there has been, in addition to the now Special Populations Workgroup, there's a number of reports and other things that CBHCS in partnership with the criminal justice community has put together around the NGR process, the competency process, the restoration process, that we would be more than happy to share. There's a lot of good recommendations about how we could improve that process. And so I do think it would be helpful to share that with whatever work group was appropriate. We'd be happy to do that with our partners.
Good. Thank you, Stix. That's very helpful. All right. So maybe to close the loop on this, maybe this is something that we could put in the court of Delegate Watts's work group, Senator Mason, if that makes sense to you.
Well, thank you, Mr. Chairman. I very much appreciate, a review or a discussion of it. I think it's super important with, Heidi mentioned in GRI, about 38% of Eastern State are in GRI. So their average 6-year stay, right? So there's 38% of beds that just are not available. And now another 50% of those coming in are forensic population. Even a government history guy like myself can do the math and realize, well, there are not a whole lot of beds available. And when they come available, they're going to these forensic cases rather than the civil cases that are really someone that's sitting at home with their aunt or cousin trying to get help, and they just keep falling down the ladder because they can't get the help. Or they end up in our emergency departments, which we'll discuss tomorrow.
Senator Mason, you're new to this commission, but you've put your finger on the issue. Sarah, before we adjourn or go in that direction, Ms. Stanton, do you feel like you have enough direction on how we're going to proceed on these 3 items? Very good. All right, unless there's any other discussion from the work group, our work will stand adjourned. Thanks, everyone. Have a great day.
Thank you, Mr. Chairman. Good job.